And now with that, I think I'm going to ask Hugues. We will open the first session, and I'm going to ask H Chabriat. I think everybody knows H Chabriat in the field of CADASIL. We've been working together for more than 20 years, and he's presently the head of neurology department in Lariboisière Hospital. So Hugues, if you would like to start.
Thank you, Marie-Germaine. It's also a privilege to be here with you today. I would say that I joined the research on CADASIL 20 years ago, exactly. I was finishing my residency, and Marie-Germaine offered me to participate to the first study, the study of the first family. And I was mainly interested in the clinical and imaging aspects of the disorder. I will immediately start because the time is limited, and I will present you the main clinical features and natural history of this disorder. Here is the slide that we reported in the Lancet Neurology summarizing the main features of CADASIL. White matter lesions appear between 20 and 30 years of age, and the main symptoms are presented here. Migraine with aura is observed and reported by 20 to 40% of patients in the different series of the literature. And you can see that some patients present their first attack before the occurrence of T2 white matter lesions. Ischemic stroke are observed in 2/3 of patients, and with the progression of the disorder, we observed executive dysfunction and different type of symptoms such as mood disturbances, apathy, and the development of disability with the occurrence of dementia at the end stage of the disorder. In fact, we can enter the disorder with these different symptoms, and you can start the clinical manifestations in CADASIL with migraine with aura, with ischemic stroke, mood disturbances, and so on. And you can see here the analysis of the inaugural clinical manifestations that we evaluated very recently in our common cohort with a German group directed by Martin Dischgans. And within 358 patients, migraine with aura was reported as the first manifestation of the disorder in a large part of patients, in 36% of patients. TIAs were reported by 14% of patients, and ischemic stroke in 23% of patients. That means more than nearly 3/4 of patients presented with these three clinical manifestations as their first manifestations of CADASIL. But you can also enter the disorder with cognitive impairment, gait and balance problems, psychiatric and mood troubles. Migraine with aura is, as you saw, one of the most important manifestations of the disorder and the earliest clinical symptom of CADASIL. You can see here the result from an artist who had a scanner and who drew his aura, visual aura, with a doctor. And in CADASIL, what we knew, this was done 10 years ago, in 41 patients who had attacks of migraine with aura. We already knew that migraine with aura occur earlier in women than in men. And you can see here in these 41 patients that the mean age of onset of migraine with aura was 26 years of age in women and 10 years later in men. And you can see here that some women presented their first attack here at 6 years and here at 14 years. And we collected very detailed information concerning migraine with aura in our Paris-Munich cohort. And in 378 patients, we are able now to confirm this trend with migraine. 10% of women who presented their first attack of migraine with aura between 5 and 15 years, the peak between 16 and 30 years for women, and the peak of their first attack of migraine with aura in men, but between 30 and 40 years of age. Which type of migraine? We have also new results, and these are original data. You can see here that headache are reported by 94% of patients in our cohort. Symptoms are reported by 94% of patients, and headache by 70% of patients. But migraine with aura, with satisfying the IHS criteria, are actually reported by 1/3 of patients. A large percentage of these patients present only with migraine with aura. Migraine without aura is observed by in 23% of subjects, and 10% of them present only migraine without aura. And finally, 12% of the subjects in this cohort had both migraine with aura and migraine without aura. The type of aura is variable, but an original feature of migraine with aura in CADASIL is that we can observe in patients some atypical migraine with aura, such as basilar migraine, hemiplegic migraine, or aura without headache. Here, 6, 5, and 7 patients with this atypical migraine with aura in one of the first study reported by the German group in 1996. And we came back also to these aspects with a detailed questionnaire in our patients concerning the type of aura in our cohort. 88% of patients who had aura symptoms had visual aura with all classical manifestations of visual aura. But what is interesting is that 20% of patients had motor symptoms in some of their attacks, and 20% had other symptoms such as confusion, decrease of alertness, or ataxia in one at least of their attack. Well, we go now to TIA and stroke. This is the key symptom of CADASIL, of course, because it is a cerebrovascular disorder. And here is the here are the main features of ischemic stroke in this disorder. They are reported with a percentage varying between 60 and 85% of patients with CADASIL. The mean age of first stroke is 49 years in the largest series, and the average incidence is about 10 per 100 patient years in the large series of the literature. Usually, we see 2 or 5 recurrent stroke in patients during their life. And usually, all ischemic events are invariably subcortical. Lacunar syndrome and typical lacunar syndrome are reported in 2/3 of cases. And another aspect is that CADASIL is often recognized because there is no vascular risk factor in these patients. And in most cases, actually, there is no conventional vascular risk factor, but 20% of patients can have hypertension associated, and high cholesterol and smoking is finally quite often observed in patients with CADASIL, in about 50% of patients in some series. And interesting, you can see here a typical stroke with a small infarction on diffusion-weighted images in the thalamus and in a patient who had an acute hemisensory deficit. But we can observe also in some patients multiple lesions. We have reported in 2006 3 cases who presented with these lesions. The first one was a 51-year-old man without vascular risk factor, and he had his third stroke with a left hemiplegia. Note that the blood pressure was 150, and you can see on the MRI multiple hyperintense lesions, multiple acute infarction in the disorder. The case 2 was is a 44-year-old man who had no vascular risk factor. He presented acute episodes of instability and paresthesias, and with sudden right-sided dysarthria and hemiparesis. His blood pressure was also quite low, between 100 and 130 for the systolic blood pressure, and with some episodes of hypotension. I think this is interesting concerning the pathophysiology of the disorder. And you can see also in these patients multiple ischemic lesions in the brainstem and in the hemisphere. The case 3 was a 54-year-old woman, no vascular risk factor, and at her 4th stroke with acute right hemiparesis, with blood pressure also quite low, hyperintense lesions on diffusion-weighted images. And this was also observed by other colleagues in the literature. In this case, a 48-year-old woman who had an acute short-term memory loss and word-finding difficulty. The blood pressure in the case report was said to be normotensive, but we do not have a lot of details. And you can see in these patients also multiple small infarctions. And here also another case with a 42-year-old woman who had a sudden fall and abulia, and the blood pressure was quite low, and you can see diffuse hyperintense lesions on diffusion-weighted images. Sometimes you can also observe intracerebral hemorrhages in CADASIL, and we can find in the literature different cases. This is an interesting case with a patient who presented with a very high blood pressure and who had both ischemic lesions and hemorrhagic lesion in the brain. You can see here cases from the Italian group with 4 cases, in fact, and deep hemorrhages observed in all of them associated with hypertension. Here another case with a small hemorrhage in the frontal area in a patient who had a normal blood pressure but who was using steroids. And Rinocchi and collaborators reported all these hemorrhagic cases in a recent paper, and we can observe in nearly all cases that hypertension was extremely frequent. The other manifestation of the CADASIL is the neuropsychiatric problems and mood disturbances. These are frequent features of the disorder. And you can see here the main neuropsychiatric manifestations of CADASIL reported in a systematic study that we performed in 132 patients using the neuropsychiatric inventory. And our psychologists observed in quite a large cohort, 132 patients, that 46% of them presented with a history of depression or dysphoria, 44% had disturbed sleep, 41% had apathy, but 13% also presented with episodes of disinhibition. And apathy is really an important problem in CADASIL. Apathy is the reduction of voluntary or goal-directed behavior, and it is not reported by the patient, but by the family. And apathy is frequent. 40% of patients in our cohort presented with apathy. And you can see here that apathy compared to apathetic patients compared to non-apathetic patients are older. They are much more often men than women. They had cognitive difficulties, and they have more often gait disorders and dementia. These mood disturbances are often observed in association with apathy, but they can be also isolated. They can be inaugural, and the mood disturbances are very frequent, between 20 and 40% in the largest series. And most frequently, severe depression is reported in CADASIL patients. Sometimes dysphoria and manic episodes are observed as in bipolar disorders. Recently, using a systematic also clinical interview for the DCM-4 criteria by psychiatrists, the Italian group reported that a lot of patients, 74% of subjects in a relatively small series, had also symptoms such as depressed mood, feeling of guilt, insomnia. And during the lifetime period, 6 of these patients had typical symptoms of manic episodes with increased motor activity, sleep disturbances, or irritability. What about cognitive decline, which is the important symptom of CADASIL? We clearly see here the first manifestation of cognitive decline in CADASIL patients. With Eric Jouvin and Sonia Reyes, we had the opportunity to evaluate 22 CADASIL patients recently who were not demented, who were not disabled, and who had normal cognitive performances. And you can see when you test the executive functions that everything is okay, and there is no difference compared to healthy controls concerning inhibition, flexibility, verbal fluency, etc. The only problem is the time to perform these tests, because all time-related tests were altered, and we can see that the speed and cognitive speed is reduced at the early onset of CADASIL. After, executive dysfunction is the first manifestation and the most frequent manifestation of the disorder. And you can see here that nearly all patients after 50 years of age present with more or less alteration of executive dysfunction. In contrast, the other cognitive domains are not always affected, but with time and with the progression of the disorder, all cognitive domains will be affected. And at the end, a diffuse dementia will be observed in this patient. We tried to go deeper concerning the memory impairment in these patients, and we used specific tests to evaluate the immediate recall after encoding. And this is the process of memory with encoding, storage, and retrieval. And here also we tested the recall of information with delayed recall and recall with cues. And we observed that patients who had memory impairment were in CADASIL were older than those without memory impairment. They had a lower education level. They were more frequently men than women, and other cognitive manifestations were also associated with this cognitive impairment. Interestingly, it is also possible to evaluate the role of hippocampus using these tests, because it has been shown that hippocampus is playing a central role in the storage of information when you test memory. And you can evaluate whether there is a poor free and delayed recall with adequate encoding but little or no improvement by cueing. And this is a typical feature of memory impairment observed in Alzheimer's disease. And in CADASIL, we observed that 20% of patients with memory impairment had the profile of memory impairment observed in Alzheimer's disease. But in general, when you use different tests, the profile of cognitive impairment in CADASIL is very similar to that observed in patients with lacunar stroke and who develop cognitive manifestation. What about disability? This is we are now at the end stage of the disorder, and we have performed recently with Yao Ming from China, who came in our group to work with our team, a study concerning the degree of disability in these patients. You have here the ranking scale, and we observed that a significant proportion of patients had severe disability, but they had a very low NIH stroke scales. That means few motor deficits, few focal deficits, I would say, evaluated by the NIH stroke scale. And this is because 1/3 of these patients presented with gait disturbances, 1/3 with balance troubles, and 10% of them had cognitive impairment. And this is our important components of disability in CADASIL, as well as the deficits observed after a stroke recurrence. Dementia is reported in 20 to 30% of patients. Usually it starts at about 60 years of age. It is a typical subcortical dementia with a stepwise or progressive deterioration. An important feature is that dementia can be observed without any history of stroke in 10% of patients. And this is a small vessel disorder. It is often associated with pseudobulbar palsy and reported in nearly all patients before death. With Sarah Benisti, we tried to see if CADASIL patients satisfy the most refined diagnostic criteria of vascular dementia. And you can see here the main symptoms observed in demented patients that we evaluated in detail. And you can see that the large majority of these patients had urinary disorders, gait disorders, pyramidal things. But only 57% of them had a clinical history of stroke, and other symptoms were classically observed with this type of dementia. What is interesting is that they cannot satisfy the classical diagnostic criteria of vascular dementia because demented CADASIL patients can present without any history of stroke and without any focal symptoms. A major effect observed in CADASIL is the gender effect. And we have reported with Ben Zegunda, I forgot the name here, but that women had were less severely impaired than men. And you can see here the ranking scale of the NIH stroke scale was lower in our large cohort of patients compared to men after adjustment for age, after adjustment for education level. And the difference was not obvious before 50 years of age, but after 50 years of age, women were clearly less severely affected than men in CADASIL. At the end stage of the disorder and just before death, what are the symptoms observed in the patients? Here, Christian Operk from the German group reported the main symptoms in a retrospective analysis of all data available before death in a large amount of CADASIL patients. And you can see that nearly all patients present with a severe clinical condition with tetraparesis, urinary incontinence, dementia, dysphagia, and which are the the main features observed in bedridden patients with very severe motor deficits. There are other clinical manifestations in CADASIL. You should note that seizures can be observed in CADASIL. 10% of patients can present with seizures. But there are also different clinical manifestations reported in different reports in the literature: Parkinsonism, vestibular manifestation, amygdalism, peripheral sensory symptoms, myopathy, spinal cord manifestation, visual loss, but they are observed in 1 or 2 patients, and they are mainly probably coincidental. In conclusion, I would say that CADASIL is a severe condition progressing over several decades. The most frequent clinical manifestations are migraine with aura, TIAs and stroke, gait disturbances, mood disorders, cognitive decline from executive dysfunction to severe dementia associated with apathy. Seizures can be also observed. Severe disability is more frequent in men than in women after 50 years and can occur at different age, from 45 to 80 years, although most patients are severely affected after 65 years of age. I would like to end and to thank all the collaborators and clinical participants in this study. For the clinical team, Dominique Hervé, Nassira Alili, Jérôme, Maoué, Frédéric Buffon, and our queen, Marie-Germaine Bousser, who are seeing every day patients and who are evaluated and in contact with our patients. For imaging data, we are working daily with Jean-Pierre Guichard, with Éric Jouvin and François Deguillot, who are working on the data analysis of these imaging features. We are also in close contact, as you know, with our colleagues in Germany, with Martin Dischgens, Marco Düring, Niels Peters, and Christian Operk, who are working together with us, with Shahin Pashai, who participate to the imaging evaluation of our cohort. We also work daily with Elisabeth Tournier-Lasserve and Joutel and their team in the lab. I would like also to thank our neuropsychologist, Annie Kurtz, the queen of the neuropsychologists, Sonia Reyes, H Chabriat, and others. I would like to thank the clinical researchers who accepted to come and to work with us. Anant Viswanathan from USA, Stéphane Eppelbaum, Claire Gobron, Sarah Benisti, Benz Gunda from Hungary, Zuyi Chang, and Yao Ming now from Beijing. And I would like to thank Jocelyne Ruffier and Solange Hello, who work also together with us and close to the families. And thanks a lot to the Association CADASIL France, to the families, to the patients who participated to this study. Thank you.
Many thanks, Hugues. In fact, we are going to go to the next presentation and have a discussion after the 2 presentations, because that's going to be the neuroimaging. I don't know, Hugues, how you're going to do. You are 2 speakers, no?
Yes, I start.
Okay.
Where's Marco?
Where's Marco?
Come
okay. Okay. So
you have a seat.
You need a seat.
Or here. Oh no, this is the part 2.
Okay, please.
Imaging from